So this is presenting over the lateral iliac crest and down the lateral aspect of the. So one of the most common causes you need to start thinking about in the sports injury clinic setting is greater trochanteric pain syndrome. And this is a syndrome, so it includes a variety of anatomic causes specifically. It includes things like greater trochanteric bursitis, which overlies the lateral aspect of the hip of the greater trochanter. Gluteal tendinopathy, involved in the glute medius or glute minimus tendons, most commonly. IT band tendinopathy or tensor fascial lata injury. And you can see on the diagram there on the right-hand side the various sites for those affected areas. In terms of the mechanism of injury, we often see individuals who are runners or cyclists, particularly if they're training on banked or curved surfaces, doing a lot of hill work, presenting with this lateral hip pain. We also see it in inactive older patients. Oftentimes these individuals have developed problems with their gluteal tendons due to disuse, and there can be signs of inflammation or tendinosis on the affected area. In terms of examining an individual with this kind of problem, they may have an antalgic gait. They may have a positive Trendelenburg where they're dipping on that side. They often have pain on palpation. So this is very important to know your anatomy. If they have pain that's slightly more anterior, it may be a tear or a strain of the tensor fascial lata. If it's directly over the greater trochanteric area, it may be a problem with bursitis. If it's more in the posterior region on the gluteals, as they wrap around and insert onto the greater trochanter, it may be a problem with the gluteal tendons. So not only pain on palpation, but resisted testing. Weakness on hip abduction may be an effective problem for these individuals. Particularly for gluteal tendinopathy, resisted derotation, external rotation has been shown to be a sensitive exam maneuver for people with focal gluteal tendinopathy. In terms of investigations, you want to order an ultrasound if you're suspecting a source of pain from one of these sites. It can confirm a focal bursitis or a partial tear to the affected tendons. An MRI will also be very useful. In terms of managing these individuals, there was a recent study that was produced showing ultrasound results in individuals with greater trochanteric pain syndrome, and less than 10% of the time it was a focal bursitis. So oftentimes individuals will be diagnosed with a greater trochanteric bursitis and be given a steroid injection. This is often indeed a minority of the cases, and often it's the affected tendons that are the problem or the fascia. So it's important not to jump right to a cortisone injection in these individuals. You want to make sure that you're diagnosing the correct source of pain. But you can use an anti-inflammatory, begin a therapy program with active release or strengthening for an individual. Cortisone may be useful if there's a focal bursitis or a chronic tendinosis individual with chronic gluteal tendinopathy who hasn't responded to other things. You might consider a cortisone injection as well. However, cortisone has been known to weaken affected tendons, so you do have to use this with caution. Possibly a more appropriate therapy would be something like a platelet-rich plasma injection, which has known anabolic or growth factor activity. Lateral femoral cutaneous nerve impingement or entrapment. It's a compression of the affected nerve. It's also known as neuralgia paresthetica. This is often caused by repeated hip flexion or tight belts. You may consider differential of things like OA or FAI. If there's an obturator nerve impingement, or if there is a radicular referral pain from the back in the L1 to L3 nerve root areas. Individuals are often overweight. They may be pregnant. They may be presenting with a burning or tingling in the anterolateral thigh. It's a clinical diagnosis. Oftentimes it involves release of the compressive object, whether it's a tight belt or pants, avoiding the compression position in cyclists. They may also commence a period of physical therapy and anti-inflammatory. Lumbar Radiculopathy. So these are individuals who may be presenting with a L5, S1 nerve root irritation from the back from various sources. We'll get into this a little bit more in posterior pain, but it may also be a cause of lateral hip pain in individuals, so it needs to be something on your differential. Regarding posterior hip pain, there's a variety of separate diagnoses we need to also. Again, hip arthritis, however, pops up here as well. Individuals with hip arthritis typically present with anterior groin pain or anterior thigh pain. However, they may also present with posterior buttock pain. Oftentimes, individuals will point to both sides, the front and the back, almost as if you can draw a straight line through and through. So hip osteoarthritis is something you should. Gluteal tendinopathy is another common source of posterior pain as well, involving a strain of the gluteal tendons all the way to a partial or complete tear. More commonly seen in runners or cyclists, again, training on those bank surfaces, or again, in inactive older individuals. In terms of the examination, they may have, again, a positive Trendelenburg, pain on palpation, pain with resisted hip abduction, or resisted D external rotation. An ultrasound or an MRI can help you with this diagnosis once again, and similar to the previous slide, anti-inflammatories, an activity modification period involving therapy with gluteal strengthening, such as the clamshell exercises, resisted hip abduction exercises are very useful. Again, you may also consider a cortisone or PRP injection. Lumbar radiculopathy. So, with posterior buttock pain or hip pain, you must consider sources of referral pattern pain from the back. If an individual has lumbar spondylosis, degenerative disc disease, or focal disc herniation, this may be compressing one of the nerve roots. In addition, facet arthritis can do this as well. If somebody has spinal stenosis, that will also particularly cause problems with radiating pain down the back. More commonly, you're thinking about the L5, S1 nerve roots in this area. Differential diagnosis includes gluteal strain or Piriformis Syndrome. In terms of the examination, you want to make sure that you're doing a comprehensive full back examination that involves a complete motor, sensory, and reflex examination as well. They may have a restricted or painful range of motion of their back, positive straight leg raise or slump test. Their power in the affected muscle groups may be weak. They may have altered sensation along that dermatome and diminished reflexes. Investigation would include things like an X-ray or an MRI, possibly an EMG if you were uncertain about the dermatomal distribution. Management includes options like a brief period of rest or anti-inflammatories with physical therapy for relief positions. You may eventually progress to something like a McKenzie or McGill program for core and low back strengthening. In individuals who do not respond, you can consider an epidural or nerve root steroid injection. Ultimately, some individuals might need to progress to a surgery with a microdiscectomy or decompression. Piriformis syndrome, this can also be a cause of posterior hip pain as well. This is entrapment of the sciatic nerve by the piriformis muscle. In approximately 15% of the population, the piriformis muscle splits and the sciatic nerve comes through. If the piriformis muscle is being overused, if there's a cause of inflammation or possibly even partial tearing, the sciatic nerve can be affected as it goes through that muscle group. However, oftentimes this is a overdiagnosed phenomenon. For true piriformis syndrome to be the case, it needs to be a radicular pain that goes down not just to the knee, but past the knee and down into the foot. So we need to be careful that we do not overdiagnose this. Differential diagnosis does include things like gluteal strain or lumbar radiculopathy. It may be reproduced with flexion, adduction, and internal rotation when you're overstretching the piriformis and causing compression on the sciatic nerve. It is a clinical diagnosis. Again, if you're considered referral pattern pain from the back, you may want to get an MRI of the lumbar spine. In terms of managing these individuals, you want to perform a piriformis stretch and then undergo pelvic strengthening, look at their mechanics, and other factors you might be able to. Hamstring tendinopathy is also a cause of posterior hip pain. Oftentimes involves a sudden deceleration with the hip in a flexed and knee extended position. Commonly water ski sport or injury, or if they're having a problem where they suddenly decelerate in soccer, can cause this kind of problem. In terms of the differential, you want to be always thinking about an avulsion fracture, again, particularly in the younger athletes, a gluteal strain, or again, referral from the back. On examination, they may have an antalgic gait, they may have heard a pop, they may have bruising or palpable defect over the affected muscle group. Oftentimes they may have a stiff gait as well. And oftentimes they're also weak in their hip extension and have pain with resisted testing. X-ray to rule an avulsion fracture should be done. You can also consider an ultrasound or an MRI if you think there's a significant injury to the hamstring muscle group. A brief period of rest, anti-inflammatories, or therapy might be useful in individuals. There was a recent study done also as well in professional soccer players looking at the use of PRP in acute injuries, and it suggests that there might be a role for PRP in these individuals, leading to a quicker return to play time of approximately 2 weeks. In individuals where there's an avulsion fracture, this is if there's significant displacement, and it is thought that it would be necessary, surgical intervention might also. Now, we'll consider a few particular conditions unique to the pediatric athletes that we also need to consider when an individual is presenting with hip. So SCFE, or slipped femoral capital epiphysis, is an injury to the metaphysis, and this slips while the epiphysis stays in place. This is due to mechanical forces acting on the young, immature, developing growth plates that hasn't quite ossified yet. It's a very common adolescent hip disorder. In fact, it's the most common one. Oftentimes, it's more in overweight individuals, more commonly in males in the ages of 12 to 14. And in approximately 25% of the cases, it is bilateral. And you can see a picture there on the right of a SCFE injury on the x-ray. In terms of the differential, again, with a pediatric athlete, you need to be thinking about different causes as well. Things like septic arthritis, transient synovitis, or an avulsion injury should be on the differential. Kids with this condition may have an antalgic gait, so they may be limping, present with groin pain or anterior lateral thigh pain. Typically, they may have an obligate external rotated position or shortening the leg, and then they often have pain with impingement maneuvers such as internal rotation or fadeur testing. You always want to start with an x-ray in these individuals, which includes an x-ray of the AP pelvis and a frog leg lateral. You'll be looking particularly for something such as Klein's line, where it's a line drawn from the femoral neck towards the femoral head. In the bottom picture there, it is shown if there's any degree of offset, then they do have a SCFE injury. And this is a surgical intervention involving in situ fit. Perthes disease, or Legg-Calve-Perthes disease. This is, again, similar to the adult condition we saw earlier. It's a problem with an interruption of the blood supply to the femoral head. So it's oftentimes an idiopathic, but again, coagulopathy has been shown to be an increasingly recognized source of this problem. Eventually, the femoral head begins to collapse, and this results in pain and dysfunction. More commonly, it's in males, in Caucasians, and typically in a younger age group compared to a SCFE injury between the ages of 4 to 8. Again, differential is listed there. In terms of the examination, they may have an antalgic gait or Trendelenburg gait, intermittent groin, anterior thigh, or medial knee pain. They also may have a reduced internal rotation. Again, you always want to start with an x-ray, and the lateral pillar classification is the classification system that is used. MRI is more sensitive to also pick up this condition. In terms of the management, most cases can be managed non-operatively. So it's a young individual, less than 8, if they have a lateral pillar A, Legg-Calve-Perthes, or collapse of the femoral head. These individuals can be managed with a non-weight-bearing on crutches program with progressive gradual return to function with a progressive range of motion therapy program. Now, the goal here is to keep the femoral head within the acetabulum to allow that reossification to occur. However, if it's a lateral classification of pillar B or C, these individuals often do not do nearly as well, and a surgery is often recommended involving an osteotomy. And in pediatric athletes, you always have to be thinking about pelvic avulsion fractures. Oftentimes, these individuals go misdiagnosed as a muscle strain, when in fact they have avulsed a period or a portion of the growth plate where the affected muscle and tendon junction is stronger than the bony attachment from the growth plate to the bone, and as a result, it pulls off the peels of the bone with it. So again, knowing the anatomy is very important. You can see the picture up on the upper right there with the various bony attachments for the different muscle groups around, tendon groups around the hip. So an eccentric contraction is the mechanism of injury for these individuals. If it's the anterior superior iliac spine, hip extension, or some sprinting or jumping. If it's the anterior inferior iliac spine, mechanism of injury would involve a kicking or hip extension maneuver. Again, differential diagnosis includes SCFE, transient synovitis, or a sports hernia. And they may hear a pop or a snap. They may present initially with a completely normal gait. They may be limping. And they oftentimes have pain on palpation over the affected bony attachment and weakness of the affected muscle group. So you need to make sure that you're testing the various muscle groups around the hip in this case. An X-ray is often more than enough to make the diagnosis. In some individuals where there's a complete avulsion, if there is a stress reaction that's occurring or an epiphysis where there is a inflammation in the growth plate, then an MRI would be required. However, for an avulsion fracture, oftentimes you can see it on an X-ray. If you need further characterization or you're highly suspicious, a CT may be considered. In the bottom right photograph there on the X-ray, you can see there's an avulsion over the lesser trochanter where the iliopsoas tendon would go and insert. In terms of managing these cases, most of them can be managed non-operatively with a period of partial weight bearing for 2 to 4 weeks with a progressive gradual range of motion and strengthening program. There was a recent article in the BMC Musculoskeletal Medicine Journal 2017, I believe, that showed a possible quicker return to play in individuals who were managed with surgical intervention. By approximately 1 week, these individuals were able to return quicker to their activity compared to individuals who were managed non-operatively. So there might be a shift in the future towards some athletes who are higher level in terms of getting them back into their affected sport with a surgical intervention. However, surgery most of the time currently is being reserved for individuals with significant displacement of more than 2 centimeters, or if there's been a non-union and an individual has gone through the non-operative program and has not had satisfactory results. And that is the end of the presentation. These are the references listed for the presentation. I hope that gives you a sense of the various conditions you need to consider in an athlete presenting with hip or groin pain, the lateral hip pain, or posterior buttock pain, and having a general approach to that complaint. Thank you very much.